Noor, let me know when you are ready and you are on, when you are on live stream.
Okay, should be 30 seconds.
Thank you. I think it's time to start now.
Just
السلام عليكم ورحمة الله وبركاته. زميلاتي وزملائي الحضور الكرام، شكرا لكم على حضوركم مؤتمر الجمعية الطبية العراقية الموحدة في بريطانيا وآيرلندا لهذا اليوم، والذي يعقد أيضا بالتعاون مع نقابة أطباء العراق وجمعية هلال الأحمر العراقية. مؤتمر اليوم هو عن جراحة السمنة، والجميع يعرف بمخاطر السمنة، وخاصة في هذا الوقت مخاطر السمنة مع الكوفيد أيضا. سيكون معنا أساتذة كبار في جراحة السمنة Bariatric Surgery، منهم مستر دريد عباس من استراليا، منهم الأستاذ أيضا مستر عقيل سمير من بريطانيا، ومستر علي الحمداني من لندن من بريطانيا. ويشرفنا يكون معنا الدكتور عادل أبو مراد، الشخصية المعروفة في هذا الحقل والليد في الروبوت سيرجري في البارياتريك سيرجري. قبل ما أسلم الحديث إلى دكتور مؤيد عزيز اللي هو تشير لهذا المؤتمر، أحب أنصح أنه الإخوان جميعا الأخوات أنه تخلون الميكروفونات على ميوت رجاء حتى الجميع يسمعون بصورة جيدة. أولا راح يكون هناك رابط سنبعثه لكم على صفحة جهة الشات، تملي الاستمارة حتى تحصل على السيرتيفيكيت والتي ستصلك آنيا باللحظة بعد ما تملي الاستمارة. وأيضا مفيدة لنا أنه we know about the feedback so we can improve our practice and service. Also, I'd like to invite you all for next Friday. Next Friday, we'll talk about COVID vaccines, the scientific facts and the myth about the vaccines. Please invite all the people you know. I mean, it is not only for doctors or medical or health personnel, it is for everyone. We will have Dr. Tahsin Salim, Dr. Shakir Jawad, and Dr. Ali Aziz, and it will be a very good opportunity to answer the questions about the COVID vaccines with all the facts and all the confusion we all have because of what's going on in the media and social media. If you have any question, please write that on the side of the chat, and at the end, Dr. Moyed will collect them all together and ask the speakers. Once again, thank you much indeed for joining us, and I wish you a very good and fruitful meeting today. And the mic is to you, Moyed. Thank you all.
Thank you. Thank you, Rafid. الأخوة والأخوات والزملاء والزميلات الحضور الكريم، السلام عليكم ورحمة الله وبركاته. It's a great pleasure and an honor to host this international bariatric conference organized by the United Iraqi Medical Association in UK and Ireland. May I first thank on your behalf our distinguished speakers for taking part in this amazing conference. Today, we have 4 renowned and distinct speakers accumulate between them decades of practice and experience. They will be presenting the extract and the essence of their experience. So thank you, speakers. Second thing, I would like to share with you a reflection on the program today. When we thought of this conference, myself and Mr. Aqil Samir and the other speakers as well, we recognized the struggle of many obese patients during the COVID pandemic. Whether being a victim of the illness and suffered the consequences, and we have lost so many of patients to the virus, or maybe just adding the extra weight due to the lockdown. However little the weight, again, maybe it has detrimental effect on patients who already suffered physical and mental impact of obesity. We also recognize the ignorance of the general community, and institutions in dealing with obese patients. It's not only ignorance, it's sometimes bias as well. This was very exposed by the epidemic. When elective surgery was restarted after a long halt, bariatric surgery was the last to be considered. And that's a clear bias. We have asked our distinct speakers to address many of those issues in their talks and guide us through difficulties as well as advances in the specialty. The last thing I would like to touch on is our mission as medical community in spreading the scientific evidence-based facts, and also to fight with tooth and nails the flawed and inaccurate information spreading through the media and other platforms. The United Iraqi Medical Association has taken a solid stand on this and been in the front line in confronting the misleading and harmful information. We have taken a conscious decision to increase our scientific activities, as you probably noticed, to counteract and to face up to the challenges. We rely on your support and engagement, as we all have responsibility at this critical time to face these challenges and adhere to the science. I welcome you all to the UIMA International Bariatric Conference, and I hope you will enjoy the conference and will find it beneficial. We have two sessions today. Session one, I'll be moderate the session with Dr. Ali Al-Hamadani, and session two, the moderators will be myself and Dr. Aqil. So I will leave the microphone to Mr. Ali Al-Hamadani to present our first speaker. Dr. Ali.
Thank you, Ali Muayyad, and it was a great presentation. It was a great organization. Thanks a lot for everything, and you and Aqil and Rafid for organizing that. It was great. So let's present our first speaker. So really pleasure to have Dr. Duraid Abbas. He's coming from all the way from Australia. So thanks a lot, Duraid Abbas. It's really a pleasure to have you, Ali, and knowing about yourself. So Dr. Duraid Abbas qualification is MBCHB, FRCS, FAS-MBS. He is actually had a fellowship in colorectal, oncoplastic, bariatric surgery, very experienced. He's working now currently in Australia, in Victoria, Ballarat. He's teaching in 3 universities, teaching undergraduate and postgraduate, and also a teacher for the fellowship program for the surgical trainees. So without further delay, please, Dr. Abbas, you're going to talk to us about the bariatric surgery in Australia.
مساء الخير، شكرا جزيلا، صباح الخير للجميع، وشكرا للجمعية العراقية في إنجلترا وآيرلند على دعوتهم إلي، والزميل العزيز سمير عقيل سمير. احنا شاركنا سنين من الخدمة في العراق، مو الخدمة الإلزامية بس 6 سنوات بالكلية الطبية. احنا زملاء نضال في هذاك المكان. أنا طلعت من العراق تقريبا صار لي 30 سنة. فشكرا جزيلا. أنا عايش هنا بأستراليا الآن. الكوفيد سوى بينا شوية مثل ما يقولون بالعراقية، وخصوصا إذا البايز الموجود ضد البارياتريك. يعني الناس الآن لحد الآن عندهم مشكلة ويا البارياتريك سيرجري، وحد الآن يعني ما أعرف أنتم عندكم بإنجلترا نفس الشكل، بس إحنا بأستراليا والحمد لله أصبحنا الدولة الأولى من حيث عدد السكان اللي عندنا obesity. وما زالت institutions, general practitioners, everywhere there is a bias, there is discriminations. Everybody think that you should go and just eat less and exercise. They don't recognize it. It's a chronic disease. It's not just a disease, it's a chronic disease, and surgery offer possibly the only durable solutions, but we should accept also there is failure in our work too. So what's happened in Australia? I'm just going to share with you, hopefully my slide. I'm sure you can see it now. Let me know if you guys see that. So this is who I am. Guys, can you hear me or?
We can hear any
I can, yeah.
But
So
we don't have the presentations yet. We cannot see the presentation yet, please.
Can you, I shared it with you guys. Do you see it or?
Can we?
Try again.
Okay, I would try. I shared it.
So maybe try it again. Sometime it just locks. Allah يخليك دعاء.
Sorry. I tried to share it again. Just give me a second.
Yes,
Can you
that's
see it
right.
now?
Yes.
Okay. So as I said, I graduated from Muslim Sunnah University, and I'm very proud. As you can see in my plaque, I'm a Mr. Aqil. I know you guys like to call دكتور بس وزوجتي دائما تقول يعني درست 6 سنين حتى أصير طبيب بعدين درست 15 سنة حتى أشيل هذا التايتل. But I'm very proud that I am from Iraq. As you can see, my plaque clearly stated that I got my medical degree from Iraq, and I'm very proud of it. I use it in my prescriptions. I am very, very proud that I am from that country. Yes, I had a FRICS. I trained in Australia completely from internship to fellowship. Then I joined the American Metabolic Societies. I did 3 subspecialties. I don't know why, but I just wanted to be confident. So I did colorectal and then oncoplastic breast and then bariatric. I started with bariatric and I finished with bariatric. So I live in Ballarat. It's about an hour from Melbourne in Victoria. It's the coldest city. It reminds me always of the weather in Wales. It's a bit cold. And as I teach in a few universities and surgical registrars. This is Ballarat. Ballarat is, as I said, it's in the state of Victoria, but it's not in Melbourne. It's one of the old cities in Australia. Possibly it's hold important because there was a gold rush about 160 years ago. And from that, there was a revolution started in, which is led to what we call revolution, which are Eureka evolutions, which started the social justice in Australia with their social security system, and everybody looks after everyone. And the lifestyle of Australia, not just only laid back, but everyone should share through the tax system and help everyone else. And everyone should have access to free education, free health, and free care. And that's very important. And there's a beautiful lake we have in the middle of the city. So this is Victoria. You can see it. It's very small state. It's possibly half the size of Iraq. And this is the region I live in, and it's one of the small cities. Our region is very big. It's widespread with a population of 850, but now with the COVID, I think there was a move from Melbourne towards the regional area. I think they increased by about 50,000, but we have issues, guys. We are the highest number in Australia with a BMI over 40, 12.7. We took over from Western Sydney, which is a 12.6. So not much, but there is problems. And 35% of population have a BMI over 30, 35%. So we're suffering. But what's happened to us when COVID last year, this time, was a problem for us. So we start to hear about COVID in the beginning of January, and we start to laugh about it. Usually we were preparing to go back around the Christmas and New Year. We take about 2 to 3 weeks off. All the hospitals closed, public hospitals closed, but also the private only available for emergency, and one elective theater available ad hoc. But January, when there was a person come from Wuhan and arrived to Australia, arrived Victoria, and then we start to hear, well, there is cases. And but then on the 20th of March last year, we closed, the country shut down completely. Suddenly I was in theater, the Prime Minister was on TV saying, everybody stop. So we literally, I managed to get the next case, but everything closed. By the end of business, that's it. No travel, everybody closed, but there were no curfew, like everybody can allow to travel, but there's no travel within interstate, but there was no also travel internationally. And then there was the quarantine regime. Unfortunately, on the 22nd, we closed completely theaters, hospitals, everything closed. And of course, bariatric surgery was the first to close. So if you have a patient with even, I'm not sure whether how you guys do it, but most of my patients, they are on Optifast for about 2 to 6 weeks. And we have to close that for them and stop. We managed to have a couple of cancer cases, but on the 1st of April was shut down everything except top emergencies, life and limb, appendix, we gave them antibiotics, and gallbladder on the standby and antibiotics and treatment with biliary colic. Cancer on hold until further notice. So it was a really, really bad time, especially when you think yourself as a surgeon and you always work, but you go to the emergency department, it's absolutely ghost town. No one is there, not even a single patient. Then we started to have issues. Then things is better. We think, okay, we controlled it. The issues were two things in Australia. First is not availabilities of the PPE and the mask, and also the anesthetics medication. Propofol was, according to what I heard from the anesthetics, was only enough to for a week or two. So that's why they had to stop the elective surgery. That's what they told us. And also we had to go and find ventilators. We managed to buy about 7,500 ventilators for the state. And the projections were that we're going to need about 2,000 to 3,000 at a single time. So that we doubled from about, I think we have only 1,500 ICU bed. We managed to increase to 2,500 to 3,000, but we bought 7,000 ventilators. But that wasn't bad, thank God. So there was only a few cases here and there, and the maximum admission to ICU was in the end of April, about 48 patients in total in the whole state. So things looks good, and we didn't have any problems, but unfortunately in Melbourne, the quarantine system failed miserably. We can find the blames on different people, but that's it. It's failed. And outbreak happened, and as an outbreak happened, we have to endure 110 days of total lockdown. You're only allowed, I mean, I live outside Melbourne, so I was a bit less, but the first couple of months was absolutely, you're only allowed to leave the house for 1 hour exercise. That then extended to 2 hours. One member of the family can go out for shopping, no visitors. And I think that was hard. I think that's, and can you see the slide? Yes, we did. I mean, when I look at the numbers for you guys in UK and in United States. My in-laws lives there. And when I see in Iraq and Middle East, we laugh. I mean, this is the numbers. You guys have it every 4 or 5 hours. I mean, the maximum we had 729 cases in one day. Then the figures is down. But I think the way that the Australians wanted it, they didn't want to go for suppression. They wanted to go for eliminations. And I don't know whether that's achievable in a virus, in a community. But anyway, that's what they went for. And 26th of October, for almost 4 months, Victorian can celebrate it and say, look, yay, we did not have any new cases or deaths. We lost almost 800 citizens, mainly from the elderly. The aged care system hit bad and hit badly. And yeah, it's hurt. So that's what happened to us. Then we entered the summer summer season for us after the 900 people died. And the ring fencing, we call it here, because we isolated it from Melbourne. So there was completely the highway blocked by the police and the army. So they cannot, so Melbourneian cannot come to visit us, and we cannot even go there. Was silly, but anyway, close the border, mask wearing. Good luck for doctors. We did a good job. So this is what my life was. About 4 or 5 weeks, I didn't work. I didn't do any operations. Even when the on-call was so quiet in both public and private, I do one in 4 weeks, 4 Thursdays on call publicly, and I do one every 3 months on call publicly too. And privately, I do I think about a bit more than that. So we all stopped. And we slowly returned back. 18th of May, we returned to about only category 2. Again, bariatric surgery was not allowed, and 75 of capacities. Then in the private and 50% in the public system, absolutely shut down. People don't want to work. 1st of June, we returned to about 85 to 90% capacity private. Then I started to do about 30 cases of bariatric, but the lockdown came in July. I was shocked when I heard that we stopped completely. Again, bariatric surgery was not allowed. We only allowed category 1 during that period. So although it was nothing to do, but cancer was allowed. Then they allow us to do a category 2, which is bariatric surgery was not allowed at all. Even from the Australian, New Zealand Metabolic Society and bariatric surgery, we produced data to suggest that bariatric surgery should be considered as category 2, especially for people with diabetes, people with intracranial hypertensions, other comorbidities, which is going to get worse and deteriorated, and we loss of time. Anyway, all that went to deaf ears. And we start to work, but also we hit with another lockdown, but that this only for 5 days. That was on February. There was 9 cases found, and we stopped. It was a big fine, but when it came back to 5 days, everybody stayed at home. No one allowed to go home. Yes, we controlled it. Yes, we don't have any COVID in the hospital. Yes, the last ICU patient discharged about, they said it was in October or November. Yes, we have 7,000 ventilators. Yes, we have 3,000 ICU beds. We're all prepared, but nothing happened. Big financial impact, big loss. But the decision was from the government, from everyone else, is the life before the economy. That's what this is my room, my place called Central Highland Surgeon. As I said, my kids' school is opposite my rooms. The public hospital and private hospital are 220 meters from where my practice, and they joined by bridge, so I don't have problems. My team is 2 bariatric surgeons. We have 2 dietitians, 3 bariatric nurses, 2 psychologists, but then a lot of physicians and a lot of team members. That's my team. The girls, they do a lot of work for me. All of them nurses. They're all surgical nurses, apart from Pam. She's just a typist, but she's also amazing and doing good work for me. And the patient journey, I'm going to tell you now about it. I receive usually a GP referral from them. Then the questionnaire will be sent. It's 2 pages. Talk about the patient weight loss in the past, and whether also they smoker, whether they got addictions, alcohol, and they list all the surgery they had before and all the weight loss program they tried before, all their medications. And then we get scanned by the bariatric nurse. They will give them an appointment to see me about 4 to 6 weeks. Then we discuss with them, and then about what's the best surgery suit for them. Now, for a primary surgery, we give them sleeve, single anastomosis bypass, or 1 anastomosis bypass, and Roux-en-Y. That's as a primary. And then they will meet the dietitian, psychologist, bariatric nurses, and they will move. Then they come back to me, then I will discuss with them, and then I will do an endoscopy. I do endoscopy for all my patients, whether they are sleeve or bypass. And I take a biopsy from the duodenum and from the stomach. And then I also assess the gastroesophageal junction, the presence or absence of Barrett, the length of Barrett, because it's quite different between ultra short Barrett, and Barrett, as you possibly knows. Then we discuss the operations. Then we talk about how we prepare the patient. I try to use an Iraqi protocol where I try to use very minimum. So my anesthetists use a rectus spina block. And then also I'll show you, I'm going to use tab block and lots of local anesthetics. I wait about 5 minutes for the local anesthetic to work. Iraqi protocol, I give the patient when they wake up in recovery, I give them isopol. And when they go to the room, they start sipping on the pill cap. When they reach 4 or 5 caps by about an hour, I'll take the IV fluid and I'll take the compression stocking from them, and I ask them to start mobilize. I'll try to get them to go home the next day if they can, when they reach 1 liter. Where there is a lot of support from the dietitian. There is a special dietitian in the hospital. Of course, the nurses who work with me also work in the hospital, so they see them, and so there is a very good communication with the patient, and they know what to do if they have any problems. And then they do this 2 weeks of free fluid, puree, and soft diet. They see the bariatric nurse a week after surgery. 2 weeks after surgery, they see the dietitian, and 3 weeks they see me. Then they see me 3 months later, and then 6 months they see the dietitian, psychologist, and they see me 1 year with a blood test. Then we try to see them more often. It depends, but I try to be with them for at least 5 years, and my aim is to reach 10 years. We start to get there. Now, the operations I offer is a sleeve. I'm trying to be speed. I know my time limits. It's a great operation, easy operation, minimal technical expertise required. Just fire the gun. Really.
It's really nice talk, but really we are a bit short with time, so we're gonna maybe allow.
Yeah, I'll stop.
Now we can allow you a bit 5 minutes, maybe more, so we can maybe.
Okay, yeah, but I'm just saying it's not for everyone. So not everyone should offer sleeve. Total blood loss. Be aware of, before you fire that gun, please be aware of reflux, Barrett's, and the hiatus hernia. It's not for everyone. It's a great operation. Leak is difficult to manage, so you need a multidisciplinary team. Look for the incisura and the narrowing, and vitamin deficiencies. In Australia, it's interestingly, I was thinking in America, they don't do sleeves, but when my couple of visit there, it's a 65% of the American surgeons, they do sleeve these days. In Australia is about 45%. In our practice, about 20%. The one anastomosis, it's a new kid, really. It's been 24 years now. Again, it's a fantastic operation, easy to master. Again, I don't give it to the people with Barrett's. I think it's not it's contraindicated, but it's partially severe reflux. I mean, there's a lot of talk about it, but be aware of the smokers, guys. The smokers are really dangerous. This is not for the smokers or non-steroidal. Back to Roux-en-Y, everybody loved this operation. Let's stand the time from it's invented from our age 50 years ago. Great operation, but again, every operation have its problems. It's only 17% in the United States, it's less than 15 in Australia. I use it for Barrett, definitely. But think about marginal ulcer perforation. Internal hernias, it's a big thing. I've got a few slides, but I don't have time. I know that. Candy cane syndrome, guys. I've got a couple of patients, if they present to you with pain and you cannot find internal hernia and you are sure there is no final hernia, look at the candy cane syndrome, remove it, just reorganize it, reroute it, things will get better. Thank you very much for talking to my, listening to Australian surgeon far, far away.
Thanks a lot.
Good evening.
Thank you, Habibi. That's really very nice talk, and amazing experience. So we're open to questions. Any questions from everyone really? أي سؤال؟ زي عن ما بس تيجي الأسئلة ممكن أنا أسألك سؤال الله يخليك دكتور دريد؟
تفضل.
سؤال يعني بصراحة يعني أنت شنو رأيك ليش في أكو proper control بالكوفيد بأستراليا؟ Do you think أنه يعني إحنا بالنسبة لنا إحنا مثلا باليوكي إحنا وصلنا في يوم من الأيام أنه عدد الدث مو الإصابات فوق ال 1500 باليوم. عدد الإصابات وصلت في قسم من الأيام 20,000 30,000 إصابة. فشنو رأيك أنت ليش هالمشكلة باليوكي مقارنة بأستراليا؟ مع أن أستراليا طبعا هي 4 أضعاف اليوكي سايز يعني.
أتصور الحكومة قرارها كان نوعا ما صائب، أنه ما دام أنت قررت أنه الحياة أهم من الإيكونومي، إذا أنت تأخذ الفول لينث. نعم احنا داين 250 مليار دولار، نعم هاي راح ندفعها على المدى 30 سنة القادمة أو 40 سنة القادمة، بس أنت الديسيجن إذا أخذت قرار مثل قرار الجراحة، إذا أنت أخذت لازم تمشي وياه. وهذا القرار اللي أخذته الحكومة والشعب مشى وياه. يعني فعلا احنا عندنا 900 حالة وفاة، أقل يعني عدد بالعالم، أقل عدد إصابات، ما عندنا إصابات محلية من أشهر، لكن هذا القرار لازم تأخذ الدولة والناس يمشون وياه. وطبعا أكو ناس هوسوا وقالوا إنه هذا فعلا هوكس، وهي فعلا إنه هاي مؤامرة كونية، وفلان الشركة الفلانية تتعارض ويا الشركة الفلانية، وتعرف هذا الكلام. احنا بس الدولة الشعب كله كان ملتزم. وفيكتوريا يعني 112 يوم يعني علي مأساة كانت، يعني انت ما تقدر تطلع، ما تقدر تروح، ما تقدر تجي. تخيل اني والدتي عايشه في بريسبن 2.5 ساعة، انا لحد الان ما اقدر اشوفها، صار لي سنه و3 اشهر ما شايف. يعني مأساة، فهي مشكله بس لازم تتحمل.
بهالطريقه حافظتوا على حياه الناس. نحن عبرنا ال 100,000 deaths باليوكي اللي هي ديزاستر طبعا.
شنو سؤالك الثاني؟
agree with you completely. عندي a few questions from the floor. أكو دكتور محمد هاني يسأل what is the best type of bariatric surgery for George patients? With the patient who got gastroesophageal reflux disease, what's the best procedure for a patient who got gastroesophageal reflux disease and obesity?
Well, gastroesophageal disease is a complex again. هو عنده hiatus hernia، ما عنده hiatus hernia، عنده laxity of gastroesophageal junctions، الجريدنج مالته، عنده بارت ولا ما عنده بارت، الفولو اب اللي انت راح تسويه. severe gastro يعني انا دائما اذا اقول اذا عنده severe gastroesophageal reflux والBMI less than 50 يعني أتصور أو يعني أتصور بإيدي أني أوفر رو إن واي هاي بإيدي أني over 50 أنطيهم يعني look I will try but I'm going for single. Over 60 it's usually stage operation, single anastomosis or sleeve, then stage operation in 2 years time when you lose, you're in your 40s, late 50s, late 30s, then I can convert sleeve to single or sleeve to root and Y. It's so easy to do. Yes, it's complex, like no and ma, but remember we are two surgeons operating together, two bariatric surgeons. Our time is really fast. Most of our operations, skin to skin, are less than 40 minutes for and for rule. I mean, we're talking about rule repair of hiatus hernia and minimize the ring about 55 minutes.
Amazing.
So we don't get tired. That's what I want to tell people, that we don't get tired because there's two surgeons, two experienced surgeons. They know how you move. We use a 3D. So unfortunately, we have a robot, but we don't see that there is a room for robots in our work because we're quite fast, quite flexible. Maybe in the future, I'm hoping to learn that, but I haven't seen the benefit of this.
Amazing. Maybe another question, maybe before we pass to the next speaker, is another Muwaffaq asking is, do your patients, what is your referral time from between surgery? What is the time between surgery and referral? Is it 6 weeks?
Yeah, 4 to 6 weeks, sometimes 2 months. Look, it's depends because, again, the patient is busy, I am busy, and I've got 2 or 3 sessions a week to work in my room. Session is only 3 hours. So whether that will fit with the patient or not. But I change the days, like, I work Monday, but then 2 or 3 Mondays I don't work. So it's depend on the week. So our cycle is 4 weeks. And then we give it to the patient, but it's usually about 6 weeks to 2 months. So some people say it's 2 months.
And that's on
but then
and that's on a
that's just refer
on the National Health Service.
Oh no, we don't offer the operation in the public system. This is a private. But public system. Unfortunately, in Victoria, there's only allowed 800 cases a year to be done in about 7 or 8 hospitals. We're trying. I'm starting to try, but there is a lot of resistance. It's such a barriers from the public to start working except to do it in the public system. It's very hard.
Right. So does that mean all the patients are insured? Yani? All the patients
are insured or they pay for it. The superannuation pay for the operation, yes.
And I presume there's this type of funding or finance to do for the patients who cannot afford something like this?
Well, they have to get private health cover.
Yeah.
And then if they get private health cover, and then there is an out-of-pocket, because as Australian surgeons, we don't accept what the private insurance pay for us. There is also a gap between what the insurance pays. So we don't want to accept what's happened to the American surgeons or the doctors, when they accepted what the insurance offered them, and then they become employee for the insurance. We say, no, I've got my own price. My friend, my colleague, his next room has got different price, and the other surgeons with my room. So we have 4 surgeons in my practice. Each one's got different price, and so no one can hold us ransom for the insurance company.
Amazing. Amazing experience, Dr. Adra. It was really a pleasure having you with us. My
pleasure. Thank you very much.
There are quite a few more questions, but I think we have to go over the next.
Fire. I'm more than happy to accept.
At the end, because we're already short with time with the next speaker. So I'll go now to my colleague, Dr. Moayed, who can present Dr. Aqil as well. Dr. Moayed.
Thank you, Dr. Ali. Dr. Adra, do you mind stop sharing your screen, please?
Please, yes, I'll stop sharing.
Okay, our next speaker is Mr. Aqil Samir. A close friend and colleague to Mr. Aqil Samir. He's a consultant in bariatric surgery at Darlington Memorial Hospital. Mr. Aqil Samir has graduated also from Stanford University College of Medicine, the same batch of Dr. Dwayne did today. And he also has finished his basic and advanced surgical training in Holland before moving to UK for a fellowship at Newcastle, and then a consultant post at Darlington for the last 15 years. Mr. Aqil Senior is going to talk to us about the COVID-19 pandemic and bariatric patients and experience from Darlington Memorial Hospital, UK. Dr. Aqil, are you there? It's all yours.
Thank you very much, Dr. Mayed. Very nice introduction. I'm glad to be here today, see my colleagues, friends. I'm just to save time, I'm start sharing my presentation with you, please, guys. So, can you see my presentation?
Yes, please.
1 minute. Can you see it now? Can you hear me?
Yes, excellent. Carry on.
Okay. Actually, more or less the same difficult time what Durek talked about in Australia. We had extremely difficult time. Bariatric surgery and all elective work, upper GI, etc., all on hold, except cancer and emergencies. All stopped from March last year and February. And for us as a bariatric surgeon, it's a disaster, actually, a disaster for the patient. So it wasn't a nice time at all. The consequences was for the patient who are already on the waiting list, the patient who are in tier 3 service, because the service in UK consists of 2 steps, tier 3 and tier 4. Tier 3 who are preparing for surgery, and also for the patient who's in between tier 3 and tier 4, waiting to see the surgical team. So the consequences of the COVID-19 was really big consequences and affect the patient life dramatically. The patient on the waiting list put weight on, and then make this conflict with the guideline. And as you know, many literature showed that those group of patients, this cohort of patients, had more chance for complication, death rate, etc., if they contract COVID-19. So what we've done, we reviewed our patient from March till September. Stage 1 study actually it's to be submitted for publication. The plan to the next one to review our patient in the second wave and then make a comparison. So it's about the patient who's admitted in our trust. It's from Durham, Darlington, and other catchment area close to our trust. Well, this is and then to review the 5 different factors, I will take you through my presentation. This is the common slide, which is common that the obesity patient can suffer from all medical problems from top to 10s. And now we add a new logo on this is COVID-19. And as you see in the photo, the central obesity is reservoir for the COVID-19. As I mentioned in the beginning, it is increased so much pressure on NHS, elective bariatric surgery put on hold, also upper GI and high body mass index patient. And as you know, high body mass index patient at high risk of morbidity and mortality for COVID-19. And this is the current situation of this, I think, a few days ago in UK, about 126,000 deaths, more than 4 million in new cases. But luckily, we're heading now the right direction, and the cases in the public and hospital become much less and less and less. And hopefully, and this make us restarting providing bariatric service in our hospital. I set up bariatric service in Darlington more than 10 years ago. What we offer our patient, mainly gastric bypass, sleeve, sometimes mini bypass, and gastric balloon as the bridge for surgery, or some group of patients who are not fit for any type of surgery. The current situation, because COVID, there are about now 142 patients on the waiting list. About 457 patients in tier 3 program referred last year, but we come to proceed, cannot meet the surgical team. and 60 patients, those are ready from tier 3, but again, awaiting to attend the patient information seminar in tier 4. This is our patient pathway. I'm not taking you through the pathway, it's out of scope of this talk. What we reviewed the mortality rate in general, and length of stay in hospital, and also to compare rate of admission, ITU, length of stay in ITU for COVID-19 patients in 3 groups. We divide them, depend on their body mass index 30 to 35, and higher than 35. And we compared these factors. The area in our catchment area is County Durham and Darlington, so from south of Newcastle to north of Leeds. All patients with positive swab from 1st of March till end of September, and we collect the data: patient gender, age, length of stay in hospital, date of death when applicable, their body mass index, ITU admission, how long they stay in ITU, and what the comorbidities of those patients, especially patients with higher body mass index and the patients who are been admitted to the ITU. In total, there was 870 COVID positive patients from 1st of March to 30th of September who was admitted in hospital. I have no clue, or I didn't check how much in the community who didn't need an admissions, but this is for inpatient COVID positive. 23 patients had more than one positive swab in more than one occasion. So 18 of those being excluded because there was no, they got recurrent admission, but there was no period where negative swabs. So only 5 of those patients included in this study from those 23, because there has negative swab in between, which means the patient is prone to be reinfected for COVID by COVID-19. 119 patients unfortunately been excluded because there was no BMI record, no height and weight for different reasons. Babies were been also excluded. So this is show the data for patient. The major group is in body mass index less than 30, 471, divided equally roughly between male and female, and less than the other group is body mass index 30 to 35, again with higher than 35, more or less comparable. The oldest age group was in group of body mass index less than 30. Length of stay is more or less the same in all groups. Death rate in percentage, again, it's comparable in patient with body mass index less than 30 and patient with body mass index higher than 35. Intensive care. This show you how many patients been admitted in each group. As you see, the higher the body mass index, the more patients being admitted to the ITU, the longer stay time, and the more chance for death in the group of high body mass index. ITU. Patients who've been admitted to the ITU with comorbidities and higher body mass index higher than 30, they are 2.48 times more likely to have diabetes, and 2.11 more to have cardiac comorbidities, and 1.58 times more likely to have respiratory comorbidities, comparing with the patient with body mass index less than 30.
دكتور عقيل آسف. الرجاء إذا تدخل من الحضور الكرام إذا ممكن تسوون ميوت حتى don't disturb the flow of the presentation, please. Make yourself mute, please, all. Thank you. Dr. Aqil, all yours.
Okay. So the main comorbidity are diabetes and cardiac, actually, and cardiac is mainly high blood pressure another cardiac problem like atrial fibrillation, ischemic heart disease, etc.
رجاء من اللي دا يطلع صوتهم الله يخليكم سوي ميوت ولا you have to expel you to the webinar please. Thank you Aqil, sorry for that.
Sorry, no, it's okay. Anyway, and the other comorbidities like respiratory comorbidities, COPD, asthma, sleep apnea, bronchiectasis, and fibrosis. This again showing percentage of comorbidities divided according to the body mass index. As you see, is the cardiac is main comorbidities in body mass in both a group actually, and diabetes, and less percentage of the respiratory comorbidities.
Hello.
And also here.
Hello, ده اسمع.
This is another diagram which showed the percentage of comorbidities in patients being admitted to the ITU, which again, the cardiac and diabetes is the highest in the high group of body mass index. So conclusion one is patient, which is actually we're surprised. Patient with body mass index higher than 30 had a similar length of stay to patient with body mass index less than 30 and had the same mortality rate. And patient with body mass index higher than 30 admitted to the ITU more likely to have comorbidities with the patient with the body mass index less than 30, particularly diabetes. The second slide about conclusion actually is interesting. Patients with body mass index higher than 35 are more likely to admit to the ITU, as I mentioned in one of my slides, so 4.23 times more. And they stay longer compared with patient group with body mass index less than 35, and more chance to die is about 1.72, or higher than the patient with body mass index less than 35. So actually, the group, the problem with this patient is when they reach the ITU. So once they reach the ITU, the prognosis will be very bad for patient with high body mass index. I think the message here, which is really important, whatever the consequences are, and then we are working now with the management hard, because as the Dorate said at the beginning, that bariatric surgery being stopped or delayed or from March to October, and then we restarted again a few cases, and we went to the second wave, and again everything being stopped, and we're just starting now, end of this month again, to build slowly our bariatric surgery again. I find it really difficult for surgeons, for the patient, if the consequences of delaying or stopping bariatric surgery. So we are working hard now with the managers. I don't know how the situation other hospitals in UK, maybe Ali Hamdani can tell us, but hopefully that those patients will have the same priority as a cancer patient. Thank you very much. Happy to take any question.
Thank you very much, Mr. Aqil Samir. Very nice presentation and quite, lead us to think a lot about bariatric surgery and the way to, put a pressure on the organizations to maybe speed up or promote more surgery take place. I can see two raised hands. Dr. Hassan Jassim, have you raised your hand? Yeah, you are mute, Dr. Hassan. Yeah.
Thank you very much, Moyed. First of all, I would like to say hello to all of you, and especially Duraid, which I didn't see him for the last 30 years, and my friend also Aqil. You did a great presentations here, and we are proud of you as always. Just سؤال to عقيل هنا إذا ماكو زحمة. It's a very nice audit or study or whatever that you did here. But the most as you said, interesting things. That the high BMI guys, they have a more mortality than the low BMI. But also you mentioned that the comorbidity here with the high BMI more than the comorbidity with the low BMI. And I think that will be a confounding here or bias, because of the patient with comorbidity, especially cardiac, that's why we are expecting the death rate will be higher. So do you think that this study can change our practice? I know you are a pediatric surgeon looking to do the job, and that's your job, and we all recognize, and that's fact, that the obesity is number one cause of death and all over the world now. I mean, indirectly, still the coronary artery is still the number one cause of death, but part of the contributing factor of the coronary artery disease is the obesity. But do you think with this study here that you did, there's some confounding issue here, just because the patient with the high BMI have already cardiac disease and other comorbidity? Thanks, Aqil.
Actually, the idea of this study is to create a pressure as much as possible to not to stop or delay bariatric surgery whatsoever. And that's actually the target of bariatric surgery. We knew all those patients are cardiac patients, but we want to confirm this with number. And this number now confirmed, the more you have comorbidities, the more chance you will die. And you, as you know, even if we look at the subject from financial point of view, each day admission in ITU, it costs about £5,000. So in place of those poor guys who spend 2, 3 weeks, 4 weeks in ITU and then die, you can shift this money to the bariatric service and continue offering this service, and you will save money and you will save life.
And another quick question, if you don't mind, because I know I don't like مثل ما يقول بالعراقي يعني أنبش الجروح لك عقيل. But what's the situation of the bariatric surgery currently in our beloved country?
It is it's very it's very long and complicated topics. It is not provided as we think from different point of view. It is out the scope of this talk, but it is still in very limited capacity. And again, as any service affected by COVID-19, so we're hoping in the future this will expand and take and can be offered in many hospitals and in scientific way.
Thank you. Another raised hand from Galaxy A7. Is that Galaxy A7? I think I have now. Who's raising his hand? Okay. I've got a comment from Dr. Adra Bhumrad. It's obvious that obesity is an independent factor for severe complications and death in ICU. That's probably in reply to Dr. Hassan Jassim and to comment on your presentation, Aqil. I have one other comment on the patients in ITU, as I do ITU regularly. The difficulty one of the difficulties in obese patients, morbidly obese patients, is managing them in ITU when we need to do like proning. And one factor that has improved the outcome in our patients is the ability to prone them and ventilate them in prone position. And we have that's very, very difficult in obese patients. First, because of the size of the abdomen, also because of the weight itself. It's provide a lot of challenges to all team. And while many patients may benefit from prone ventilation and improve their oxygenation, this has not been shown in morbidly obese patients. I have no more questions, Aqil, and I would like to thank you very much.
Thank you very much.
Thank you. Can you stop sharing your screen, Aqil? And I will probably go for our next speaker. Yeah, thank you, Aqil. Our next speaker is Mr. Ali Al-Hamidani. Ali Hamdani is a consultant general bariatric surgeon in London for more than 12 years. He works at London Clinic, the Wellington Hospital, the Bupa Cornwall Hospital, and the BMI Clementon Churchill Hospital. His NHS base is Whittington Hospital. He has performed over 3,500 procedures and expert in a wide range of bariatric surgery, including sleeve bypass, revisional surgery, and so on. He has an MD degree in molecular biology and more than 300 publications. He also has attended so many conferences and been a speaker in many of them. And he's very involved in teaching, and he has also an international bariatric fellowship to new surgeons. May I welcome Dr. Ali Al-Hamdani, who's going to talk about obesity. Is it a patient fault? Dr. Ali, or Mr. Ali Al-Hamdani.
Thank you, Dr. Moyed. Very kind of you. Fine, let me just share my screen first.
Please. Yeah, excellent.
Yeah, can you see it clear?
Yeah, great. Thank you. Carry on.
Thanks a lot, Ani, Dr. Moyed, Dr. Aqil, Dr. Rafid for the organization. It's an honor to be with you again. And it's a pleasure to get away. I am calling, but it's a pleasure to get away from the on-call and be with you. So that's perfect. Hopefully you can keep me as much as you like. Fine. So talking about obesity, talking about maybe this subject is about why do we have obesity? Is it patient fault? And if it's not patient fault, then whose fault is that? It must be patient fault. Fine. We'll try to understand this now, hopefully. I work in these places in London. And this is my, I have no, nothing to declare. And this is my case mix. And usually I do about 20% revisions. And I always remember my old teacher saying to me that the more you do, the more you do in bariatric surgery, the more revisions you will do. And the reason for that is, I didn't understand why he said that. And I thought it was only experience he means, that the more you do, the more experience you get, and the more you start to do more revisions. But no, it's because, I understand a bit more now, it's because that obesity surgery by itself is not exactly the final answer to treat obesity. There must be other elements. And therefore, even if you offer them the best procedure in the world, they still need something else with time. I understand that what he said now a bit more clearer. Fine. There's a very controversial thing I'm going to say now. What is the benefit of obesity? So is there a person or an organization or industry who benefit from obesity? Yes, of course there is. In the food industry, the main beneficial parties, they are doing foods, which is lovely every time and then, and it's very delicious. And it's getting better and better, the food. The diet and gym industry, it was not even present about 78 years ago. There was no gym industry 70 years ago. What about the pharmacological industry? Now, to give you an example, we spend on statin every year 30 billion pounds, not million, billion pounds on statin every year. And can you imagine who's benefit from that? Obviously, the pharmacological industry. Now, can you imagine with all these spending of money for these industries, they will direct the research toward them. They will be biased. Their research will be biased because there's a large amount from the food industry or from the pharmacological industry to spend money more on their products. And accordingly, the research will be biased. Now, we all may be brainwashed by the idea of the advantage of statin to lower the body fats down. But who said is the body? Who's eating fatty meals is bad? I mean, we all know that eating, for example, the keto diet now, which is really good for patients who are diabetic, or really good for patients who are non-diabetic, and it improved their parameters. So actually, eating fatty food is not as bad as we thought. And obviously we were brainwashed over about 50 or 60 years by the advantage to lower the body fat and use non-fatty food. This is a very controversial idea, but anyway, it's good to think about it. In UK, obviously the obesity is only on the increase, and you can see in around 2013, 2003, there was about average BMI of 90-20 for the adults. Now 2017 is about end of the 20s, 27, 28, 29. So what exactly my patients tell me? So what my patients say to me, I can lose the weight, but I cannot maintain the weight loss. I think I have a slow metabolism. I think obesity is in my genes. And some of them also say, I have tried many diets and they don't work for me. I gain more weight after each diet. And the question here, do we listen to them? No, we don't listen to our patients. We just ignore them. It must be their fault. Now, to summarize what I'm trying to talk about here, I think this obesity is a combination of biological factors, psychological factors, and social factors. I'm not going to talk about in details about each one, but I'm going to maybe highlight one or two points in each of these causes. So what about biology? Well, these are not recent studies. It's about 7-8 years ago, 2014. There's more than 100 specific genes involved in obesity, and these genes are responsible with the interaction and the neurobiology. It affects our appetite. It affects people interest in food. It affects the ability to know when they are full, and it's even also affect being emotional eater or not. So it is a significant effect of genes. Now, this is a very interesting study in the New England Journal of Medicine, 2002. Now, the line in the middle is the normal patients, yeah? This line in the middle. And you can see it's the effect of ghrelin, study about the effect of ghrelin. And we know that the ghrelin is the hunger hormone. So the more ghrelin, the more we are hungry, the more we eat. So you can see from this one, before the breakfast, for example, we are very hungry, and after we eat breakfast, the ghrelin drops. Before lunch, ghrelin is high, and after we eat, ghrelin drops. And before dinner, the ghrelin is high, and after we eat, ghrelin drops. The last line of the ghrelin levels, this is after gastric bypass. And you can see, interestingly, patients are not hungry anymore. But the reason I put this slide in is actually to look at the top line here. So if you look at the top line here, these are the patients who are dieting. And interestingly, the more you diet, the more you have higher hunger hormones, and the more you eat. So the more you diet and you're more into going to different type of programs, that will actually work negatively on you. Your brain will be very hungry because of the ghrelin hormones increasing, and you put actually more weight with time. And that's why what they're saying to the patient, I'm yo-yoing, I'm putting the weight after each diet. That's exactly what the patient is saying. But now we have evidence to support this, what they're saying. Fine. Now, I think maybe the best way to understand obesity is try to analyze what type of treatment we give them or why this treatment is successful. So the most successful treatment so far for obesity is the gastric bypass. We call it the golden operation because everything works. Whichever you are, however you eat, whichever your BMI, it's going to be solved by gastric bypass. So let's talk about gastric bypass in a second. Let's exactly see how it works and what factors does it affect so we can maybe understand obesity. What we do with the gastric bypass, as you can see here, we separate the main stomach into two parts, top small part and the remaining big part. We separate them completely away. And then we connect this top part of the stomach directly with the small bowel. And by doing that, we're going to bypass the big stomach. That's why it's called the bypass. And then we form a Y-shaped configuration of the small bowel. So you have one limb carrying the biliopancreatic secretions, that one there. And that limb will meet this limb here, which is the elementary limb, because it carries the food. They meet together here to form the common limb, where the food is mixed with the food will be mixed with the secretions to digest the food. And this is the Y shape, and that's why it's called Roux Y shape. Obviously, Roux from the surgeon who invented the procedure about more than 100 years ago, 1,800. And why? Because this configuration. Now, everyone asks is how this procedure works. So what I say to the patients, or what everyone say to the patient, and when you open any book, you see that in any book, you said they say that this procedure is restrictive because it's restrict the amount that we eat because there's a smaller pouch in comparison to the old stomach, so it's much smaller pouch. So it's restrictive, number one. And the second thing, it's malabsorptive. So malabsorptive means it does not allow us to absorb all the food that we eat. That's what's said in the books, fine? Okay. Now, what I want to tell you today, this is a not restrictive surgery and is a not malabsorptive surgery. So what do I mean that? Now, if you can imagine, when we eat, we fill our stomach and then we cannot eat anymore. We stop because the stomach is full. For obese patients, the stomach is bigger, or it doesn't matter. They have to eat, they have to fill the stomach, otherwise they cannot stop. So we only stop eating physically because we cannot eat anymore because the stomach is full. And why we cannot eat anymore? Because there's a sphincter here called pylorus, which opens once every 4 hours. So the food have to accumulate in the stomach until we cannot eat because the pylorus is closed. The exit of the stomach is closed. So therefore we cannot eat. Now what's happened after the bypass? Well, look, this is really important. Look at here. So we eat, it goes into the pouch, but it cannot stop. The food still goes in. There's a good size hole between the stomach and the small bowel. It's about 4 or 5 centimeters. It's that big. So the food will go there and go all the way down. And the first obstructing part the food will face is the ileocecal junction, far away to the colon. So talking about 4 meters or 5 meters of free space for the food to go in. So there is no restriction. Okay, fine. That's fine. But what about malabsorption? We're going to bypass at least 2 meters of the small bowel here. So why malabsorption does not happen here? Or why do I think that? Because we know the symptoms of malabsorption, aren't we? We know the malabsorption people will have diarrhea, will have steatorrhea. So the feces is full with fat. They are not absorbing the food. We know that. We know that the patients have an abnormal absorption. We know when we test their stool we find that there's plenty of micronutrients when it has not been absorbed. Here, the opposite will happen. Patients will absorb everything. They're actually more likely to be constipated more than having diarrhea. And actually, the real malabsorption happened only in 1% of the patients after gastric bypass. So 99% of the patient after gastric bypass, they should not have malabsorption. Right. So there's no malabsorption and there is no restriction. So how does the operation works? One simple example, day 1 after surgery. So literally that's day 1. Patient have not yet have any restriction, have not yet have any malabsorption. Day 1, we stop all the insulin, we stop all the anti-diabetic medications because the glucose level go back to normal. So the weight loss not even having dropped. So the patient is normal weight. I mean, normal obesity weight. They have not lost the weight yet. But day number 1 after surgery, we stop all these medications. We stop the insulin because the glucose back to normal. So what exactly happened here? This is a very interesting experiment done by Leroux group in Ireland, and it's amazing. So what he literally done, this is an experiment in rat, and what he did, he disconnect the insertion of the common bile duct in rat. Instead of being in the duodenum, he disconnected from here and he put it down the way towards the ileum. And what he noticed after that the weight of the rats who had this operation, they are the same weight rats. The weight of the rat after who had the operation actually stays the same, while the rats who did not have the operation when they fed, it goes up, as you can see here. The weight of the rat after the operation, they're the same. And after the operation has been fed, both of them are fed, it actually increases. This does not increase, this increases. So actually, by doing that, he noticed that the concentration of bile acid in the blood increases after this operation. And by a way, this prevents the fat from getting fat. So he was starting to think of bile acids metabolism. So now we're gonna go into studies, which is done in human. Just by giving fatty acids, just by giving bile acids to patients, they had direct effect on the liver. They stopped the secretion of the glucose. They stopped the synthesis of the glucose, and they increased the synthesis of glycogen. And we know that insulin sensitivity and resistance is mainly that, is high glucose and low glycogen. Here is the opposite way around. Give bile acids, you will have more glycogen and less glucose. So literally, by giving bile acids, we are increasing insulin sensitivity and decreasing the resistance, which is the main reason for type 2 diabetes. Not only that, so the bile acid here have a direct effect on insulin. It affects the beta cell of the pancreas, so it directly increases the secretion of insulin. And also here, it will directly go to the intestinal L cells and produce GLP-1. And we know that the GLP-1 is like a profactor to produce more insulin. So suddenly, after the operation, we have decreased insulin resistance, increased insulin secretions, and patients straightforward back to normal, obesity or diabetes cured. And that just tells us that there is significant derangements in bile acid metabolism or levels in the blood for those patients who are obese. They have an obvious biological problem. The bile acid in the blood is low. Fine. What about this study? So this study showed, this is very recent, it's 2019, about a year and a half ago. It shows that the level of the type of the bacteria in the stomach, in the small bowel, is completely different in the patients who are obese. And what's happened after that, after the operation, after the gastric bypass, the type of bacteria changes into normal bacteria. And this change continues for about 12 months, and that's the time where the maximum weight loss happened. After the 12 months, the bacteria go back to normal, to the old type that these obese patients have. And that just tells us these patients have a significant problem with their bacteria and the small bowel. And we know that actually these patients, a new treatment is given nowadays. They've been given bile acids, and they're given also a certain type of microbacterium. You know, the healthy type of yogurt that we've been sold in the markets now. It helped to reduce weight in a way or another, but we don't understand why. And the study show us why. And it just tell you that obesity is not as simple as a patient fault. It's actually a biological determinant. There's a biological deficit in those patients, which is illustrated by the type of the bacteria in the small bowel and the number of bile acids available in the bloodstream. So maybe even we call these obese patients obesity problems because they're literally obese. That's why we call it obesity. We should call it something different. We should call it metabolic syndrome. And that's the new name for this problem. It's called metabolic syndrome. But even metabolic syndrome, we call it syndrome because we don't know what's happening. We have not identified a certain or number one pathology for this problem. So it is a disease, but so far we call it metabolic syndrome because we don't know. So that's our best explanation of the biology of these patients. Fine. This is only the biology. So what about socially? We talk about stress, but what's the effect of stress? So the stress affects the prefrontal cortex, which is mainly responsible for patient decision. And if that's affected or damaged, the patient can eat and eat and eat, and then they do not stop eating even when they are not hungry. So they eat and then satisfied, but because this happened, they continue to eat because of the damage to the prefrontal cortex. Now, we call these patients in our psychology as compulsive eaters, but now we know why they're compulsive eaters, because literally there's a damage to the prefrontal cortex. Yeah, fine, psychology. Now, I think this is also a major impact here, because can you imagine these patients have a common view, not between themselves also. So the patient believe, and also the community believe that it's their fault. And that's create this type of stereotypic behavior, bias, discrimination against them. And it creates this, accordingly, we have this circle of shame and weight gain. I'll show it to you here. So stress, patient eat more to soothe the effect. They gain more weight, and then they have all the people in the community look at them as their fault. They eat in the weight as they go back to stress, and a continuous cycle like this. How does that affect for the patient? Very stressful. They feel guilt, it's failure, it's depression, low self-esteem, poor body image, suicidal thoughts. Children leave their school, they change their school just to get away from these bad discrimination and getting away from those friends who always discriminate against them, although look at them as their faults, which is a disaster. Now, understanding the change. Now, we really have to put in our mind that these patients has been stigmatized for years and years and years. And whichever they try, if they try to go on a diet, different type of diet, this may be the worst thing they can do, because we know now going to diet is actually make them worse. They put more weight on. They reach a stage that they reach a weight that's impossible to be resolved by themselves. If we're talking about 10, 20 kilograms, maybe okay, achievable. Even that is difficult, I'll say. But if you reach about 60 kilograms or 70 kilograms, more than your normal weight, how would you expect the patient to lose that? Therefore, the management have to be multidisciplinary. It have to be multi-targeted therapy for those patients. Just maybe 1 or 2 points about the psychology and how to maybe address that. We obviously need to understand stress and remove the cause of the stress. For example, as simple as if you put a scale in your house and if the scale is causing you stress, take the scales away. As simple as that. We know that the different type of stress, obviously different reasons for that, like job, finance, and so on, that have to be solved. Give the patient a new starting point. Give the patient a target to achieve. There's different psychological methods, like for example, mindful eating. We know that, for example, how to manage the curve. Take a deep breath. Use this energy to do something else apart from being at home. And obviously, because of the obesity, continue to eat. But one of the most interesting ideas is eat with your family. You know now, the way we eat, or the way I work, for example, I eat in the breaks between the operation. I eat on the run to the work because I finish work at 7 or 8 o'clock. I came back and I'm already eaten. So I don't eat with the family. We have lost this touch of having a healthy, properly cooked meal with the family and discussing things with them. That's one of the major things psychology have to be addressed as well. Now, what about physically? I think physically, the main thing here is to control the proper body hematopoietic insulin and cortisol secretions. How do we do that? Literally by avoiding the sugars, avoiding the sweets, not the fat. It doesn't matter. You can have 3 meals a day. Have a full English breakfast, but not with bread. That's the whole point. Again, lunch and dinner, doesn't matter. 3 meals a day, but they're healthy meals. And this is also one of the misconceptions here. People think as exercise. It doesn't matter to do heavy exercise. That's not the point. Doing heavy exercise can build your more muscle, can increase the weight, can make you more hungry. The whole point is to prevent the muscle mass. So it doesn't have to be a heavy exercise. Simple little walks is enough. I mean, I'm not going to talk how to tackle obesity here, but the whole point here is to understand obesity really. So obesity is a disease, and we call it obesity because the patients are obese. That's the most distinguished characteristic factor of this disease. We call it obesity, while it should be called at least metabolic syndrome, because just by calling it obesity, we're discriminating against these patients. We know that the reasons behind obesity is multifactorial. We know that it's a combination of social, psychological, and biological problems that determine, and that's the main reason for people getting this metabolic problem. And therefore, in trying to treat this one, it has to be multi-targeted approach. So that's why operation fails after 10 years or 15 years. And that's why the revisions are getting more and more, because we're only giving them, for example, weight loss surgery saying, okay, this is your treatment. It is definitely a good treatment. It will affect multiple hits on the pathway to cause obesity and will treat, but we need more elements also to be addressed. And accordingly, it is definitely not a patient fault. Thank you for listening. I think I should stop now. I spoke too much.
Ali, it's always nice to hear you talking. Your lecture was excellent, and we all probably need to digest the message or the content of this presentation. So thank you very much. There are a few questions which I want to ask a couple, and then we have a few for the panel discussion at the end. So if Our colleagues, if bear with us, there's a panel discussion at the end of the seminar, but there are a couple of questions. There's one from Ahmed Ihsan. He said, doesn't this operation, referring the RUI operation, is going to neglect the mechanical movement of the stomach, which aids mixing secretions with food?
Yeah, I mean, the problem is with the weight loss with the Roux-en-Y gastric bypass. Again, it's not the restriction, it's not the malabsorption. It's got nothing to do with that. It's the hormonal effect that produce, is the level of bile acid that produce, is the level of the change in the microbacteria and the stomach and the small bowel that will produce. And by the way, all these changes are temporary. This will happen in the first year or two. And this is the chance for the patients to lose weight, and that's it. After a year, after a year, the effect of the, as we see it in these studies, the bacteria will go back to where it was before. And that will decrease the effect of surgery. And therefore, you really have to be very strict on making sure each day of these 365 days is working for the operation. Now, that doesn't mean the operation is great, as Ahmed said. I agree. There are problems with each operations. For example, as he correctly said, the mixing of the secretion will be lost. We're going to bypass long part of the small bowel, and some of the main complications that might happen after surgery is something called bacterial overgrowth, because they're going to be a blind limb of the bypassed biliopancreatic secretions, and that can cause, obviously, can cause abnormal bacteria growing. So not all the effect of the bypass is great. I know it's called the golden surgery, but as he rightly said, we're going to bypass the good effect of the stomach. Not only that, we're going to bypass the production of B12, iron, calcium. This all mixed, and all we have to replace them. But it is the, which better evil to take? The best of which evil you're going to take. So that's the whole point,
Absolutely. There are a couple of comments which I want to mention. One comment from Dr. Sahar, our colleague, Dr. Sahar Abdul Rasul. She said, Dr. Ali Al-Hamdani, this is a very interesting presentation. The gut microbiome is currently linked to many diseases, which probably is right. And the other comment, I think, I like this one. In certain cultures, probably we are all going to link or associate with this. In certain cultures, obese people are more respected.
Yes, that's right.
Now, there's another comment or question, which is probably linked to that as well. What it says here is that, sorry, it says from Arabi Al-Bujasim, Arabi Al-Bujasim.
Yes.
This changing society view of obese patients could help to manage obesity.
Sorry, what did you say? Say it again.
This is changing society view of obese patients may help to manage obesity.
Yeah, totally agree.
Yeah,
totally agree. Now, and that's it's because if you can imagine, I mean, when I was back home, يعني مو قبل هواية، قبل تقريبا 25 سنة. يعني we are raised in a culture that we all have to finish our plate. مو صحيح؟
true.
يعني I'm يعني they will be angry at me if I don't finish my plate. This is signs of love, because you love your mom if you finish your plate.
Absolutely, yeah.
والله بينما جينا هنا, it's the life changes a bit. We are a bit more into work. We left our mom in Iraq. وعفنا البقلاوة وعفنا الدولمة وعفنا هذه ف definitely can affect that. Definitely can affect the يعني the weight perception. مثل ما قال, مثل تعليقك الأول, احتمال تروح الكوميونتي other way around. يعني هذول السوموز to be thin, this is bad, very bad.
Yeah, absolutely. Now there's probably this the last one before we move to the next patient, and that's probably from a comment from me and from colleagues Huda Al-Mashhadani. Now,
Yeah.
I picked up in your presentation about the use of bile acid to reduce the glucose and increase maybe the glycogen. And what she's asking now, and that's probably very much linked, is that how do you, in my opinion, how do you link this to the keto diet?
Yes. With the keto diet, we are decreasing the use of the glucose. So we're forcing the liver to improve the insulin resistance, because there's no glucose anymore. So we're forcing the liver to increase the insulin, to improve the glycogenesis. So there will be more increase of the glycogen, improving of utilization of the fat in the body. They force the body to increase the utilization of the fat stores. Again, I'm not sure what's going to happen to the bile acids in the ketogenic diet. It's really difficult to understand what's happening in the microbiology of the absorption of these bile acids when they go into the small bowel. It's really difficult. I don't know.
Thank you very much. That was very pleasant presentation and very nice. And I hope you will stay to the panel discussion. I hope
no one call me. Yes.
Yeah. Okay. Our last speakers, I'll leave it to Aqil. Aqil, are you there to present?
Yes, I'm here.
Thank you.
Before I introduce my next speaker, I just want to comment on the last comment of the one before the last comment about changing the atmosphere or the social atmosphere and effect on obesity. Yes, I agree. Recently, a British court took 2 adolescents from their family, from their parent, and sent them for to another family, because they find the home atmosphere is very obscenogenic. And there is a very big study came a few years ago from Bristol and mainly focused on childhood and how can the home atmosphere play an important role in making the kids obese. And there's many evidence, even comparing like South Europe with North Europe, etc. I'm glad and honored to introduce next speaker is Dr. Adra Bhumrad. Adra Bhumrad is actually an international figure in bariatric surgery. He is leading bariatric surgery in his hospital in France, and he is very expert in robotic bariatric surgery. He is a proctor in Europe in robotic surgery. I had the opportunity to visit him in his unit there, and is doing an amazing job. He is able to do 4 bypasses a day, all hands-on, not using any staplers. For us as a surgeon, we knew what mean to do hands-on for bariatric cases day, including the docking time, etc. Very efficient unit, excellent team, and it's an honor for me to introduce him today in this meeting. Dr. Adil, this microphone for you.
Thank you, my friend. So first of all, I want to thank the organizing committee and especially Dr. Aqil for this nice and gentle invitation. I'm honored, and it's always a pleasure to be among friends. In my presentation, I will speak shortly, a few slides, about the impact of COVID on our surgical activity in Orleans. Then there will be 2 short videos, one treating a severe GERD in a complex case after a bypass. Then another video on troubleshooting in bariatric robotic surgery. So this slide shows 2 curves, 2019 and 2020. And we can see a deep inflection in the curve at the onset of the pandemic on March, April 2020, comparing to 2019. And we had another inflection in the curve in August, but this was due to holidays in France. If we look to November and December, the curves show another inflection due to the second wave of COVID. We did have, we was 3,000 surgical procedures short comparing the 2 years. Looking closer to robotic bariatric surgery, we did have a severe inflection in on 2020 due to a lack of demand for bariatric surgery and cancellation of procedures. This slide shows numbers of patients canceled or postponed for surgery during the pandemic. So, the video presenting a very complex case. It's about a young woman, 15 years old, 47 of BMI. She did have, in 2001, a lap band removed 6 months later for complication. Then she was operated in another facility on 2012 with a Roux-en-Y gastric bypass laparoscopically. She was reoperated 3 days later for a gastrojejunal stenosis by laparotomy. She went through several months of intensive care unit, and then she came to us in 2013 with a severe status of denutrition. After managing that, I operated her on 2013, and I did anastomosis between the blind limb of the jejunum in the gastrovaginal anastomosis. I put it back in relation with the excluded stomach in order to improve nutritional status. I did operated her later on 2014. I did cholecystectomy on 2017. I did a repair of an incisional area with putting a intra-abdominal mesh. And then 2019, I did a laparoscopy for internal hernia, Peterson defect. She came back afterward with a severe GERD, and I did a robotic procedure, and I did a posterior valve, anti-reflux valve. This is what I'm going to show you. So you can see that we had adhesion to manage here. And then I went on to the bypass, the gastrojejunal anastomosis, and I exposed the anastomosis I did afterward, putting back in the circuit the stomach, the excluded stomach. So I did the splitting of what I have did in 2013. And this is to show you that in revision surgery, robotic can be very helpful. The surgeon is in control of the field. He is in control of everything. Afterward, I went to see if there is an obstacle explaining the GERD, the trace ligament, the intermesenteric space, and the Peterson was all good. Calibrating, and then going behind my bypass, reaching here for the right cruise, and then for the left cruise. Here I'm splitting the spleen. I'm liberating the excluded stomach on its upper side from the spleen. And you can see I'm in charge of everything, the camera, the exposition, and the dissection. Here we are closing to the hilum of the spleen, and you can see the dissection is cool. We are in a narrow space, but we are seeing like if it was a laparotomy, dissecting and clearing the adhesion from the hilum of the spleen. Getting behind my bypass in order to bring the posterior valve, the posterior anti-reflex valve. You can see that I am always in control of everything I do. I don't rely on my operative aid, even though they are experienced one. Bringing the valve, the anti-reflex valve, made of the stomach excluded. Then I will begin to suture it to the right cruise. For that, I will use a non-adsorbable V-lock string on a running suture. See how it's easy to suture even in a narrow space. We are seeing a huge view of a really narrow space. I always block the two tips of my string, even if it is an unabsorbable one. I block it with clips in order not to let it later on be loose in the abdomen and provoke occlusions. So this is the beginning of my suture. See how ergonomic are the movement of my instrument inside the abdomen, blocking the other edge of my string, and now suturing the valve from the right side on the right aspect of my bypass. I use for this an adsorbable string, a V-lock 30. Once again, the movement inside of the instrument inside the abdomen are smooth, ergonomic, and the surgeon is fully in control of everything all the way through the procedure. Finishing the right side, and then next we'll go to the left one. It's a running suture up and down, then fixing the valve to the left side of my bypass. Now this is very easy to do. As Dr. Akhil said, suturing inside the abdomen is a real pleasure with a robot. In revision surgery, the robot is priceless. Even though this patient had many surgery. a little trick for me to hold the whole thing in place. And now I'm going to do a indocyanine green test to be sure that my bypass is well vascularized, and also my valve. See how flashy it is. So I am satisfied with what I have done, and I don't have any comme on dit en français, inquiétude concerning my operation. I saw her 1 month after surgery, and she did well, free of GERD. So my next video will be about troubleshooting in robotic bariatric surgery. It's a compilation of several video samples of a difficult case, mostly revision surgery. So we need to put the camera in place, do some clearing of adhesion in order to be able to put in place the robot trocars. This is done laparoscopically till we have enough place to put the trocars. It's about a revision surgery after a lap band, and here I show you a fracture of the liver while mobilizing it. It was a heavy liver, so I put it I put it up close to the abdominal wall, and did have hemostasis like this with my liver holder. And then I put my instrument, my robot instrument in place through the trocars, and continue to clear the adhesion. Now I am seeing if the bypass is feasible. So I began with my jejunal anastomosis, and I did the back row of my jejunal anastomosis. Like that, I was sure that I will be able to do my bypass in this multi-operated abdomen. I'm clearing the field of clotting blood. And this is the fibrosis after lap band. I did have some work to do to clear and the adhesion and go up to my my gastroesophageal junction. Now I'm going I'm reaching to the bursa augmenta, applying my my stapler, and due to fibrosis, it was a little bloody. Here you can see the tissues are heavily fibrotic due to the lap band, and at some time I thought I punctured the stomach up, but in fact it was the fibrosis left in place after withdrawing the lap band. But it can be quite interesting to make the difference. This is the anterior valve left in place after the extraction of the lap band. And then to have a clear view, we go back to have a back picture of the scene, and then continue our progression. We must be aware of any left in place remnants between a communication between the pouch, the bypass pouch, and the stomach left in place. This to show you that even in robotic surgery we can have a battle with an extra T, and we can struggle also in robotic surgery in certain condition, anatomical condition. Here I was doing my my pouch, and then I had acute bleeding. It's important in all surgery, and especially in robotic one, to do meticulous, calm hemostasis. And we have a great instrument to do the hemostasis. It's the biceps, the bipolar biceps. Here, after a lap band, I was opening the anterior aspect of my pouch, and I did a complete opening of my stomach. If it is seen peroperatively, it's not a big deal. We can repair it. So this is to show you that we can have complication, but we must be aware of it. And if we repair it on the spot, we don't have any problem postoperatively. So I did the running suture to close the posterior aspect of the gastric pouch, and everything went smooth. And here it is. The anastomosis finished. Here I was finishing my back row of my anastomosis, and I had what all surgeons fear, a blind hemorrhage. I was blinded by the blood, and so we must keep calm. We must keep in control of what we are doing, and the ambience in the room, because we must stay calm to allow our team to be calm also. And then we control the hemorrhage, and then we think about how to repair it. I clamp the bleeding vessel, had a clear view. I tried to have hemostasis by bipolar application, bipolar bicep application, but it didn't work. So I thought about applying clips. As you can see, it's still bleeding. So I tried clips, but it was also a great failure. So what to do? I was thinking fast, but I stayed calm because I'm not on the field. I'm on the console. So if I panic, everyone will panic, and it will go wrong. So I used my string to complete my hemostasis. And as you can see, this time it was a success. It's not the same in robotic surgery as in laparoscopy. In laparoscopy, you are on the field and we can do many things by ourselves. Here, the camera must be removed by our scrub nurse, and to have a clear view, we must give our directive, our orders accordingly to the situation. So I achieved hemostasis, and everything went good afterwards. So here, after also a lap band, while applying my stapler, and you will notice this abrupt movement, and I opened fully the stomach, and you can see the calibrating device inside the stomach. So I relocate, and then I closed the opening of the stomach as simply as that. This is to achieve the hemostasis on the broken liver, and we can use devices, hemostatic sponge, to complete it. Here I was doing a SADI, and everything went well, till I noticed something that gave me some reflection to do. Why my stitches are loose? And it was because of the string which broke up. So we must stay alert all over the surgery. And if we noticed anything, we can repair it. Here, it's only curiosity to remind you that we can discover many funny things inside an abdomen. Thank you.
Hello, thanks, Adel. Amazing presentation. I really, you are really a brave surgeon to went through this adhesive field to do this type of surgery. Revisional bariatric surgery is extremely difficult, especially in revision after gastric band, which is normal. When you go to band, there's so much adhesions, and it will be very difficult. I don't know if there is any questions. Is there any questions or any comment? If I have some questions, but if there is anyone have any question.
There's few comments. Just you know, show the appreciation of the presentation and the skills, amazing skills, and how excellent robotic surgery looks like. Although it only comes with the you know, some.
I have a question for Adel. Do you recommend esophageal manometry in patients who have had gastric bypass and plan to do fundoplication or anterior surgery?
I don't do a Nissen usually, and when you do a toupee, only a posterior valve, sometimes you don't need to have esophageal manometry. But it can be useful. It can be useful.
Okay. A stitch breakup in V-lock, it is not uncommon, and this is one of the reasons I'm not using this one. I use the other one.
This is the string that broke up was not a V-lock. It was a V-lock. It was a Philblock. It was it was imposed by I don't know who. During a certain time in our facility, and we did have many incidents like that in different specialties. So I forbid it from being used anymore, and we went back to V-lock. But we all strings can break during surgery. We must stay alert.
Do you leave drains when you do this revisional surgery?
I use drains only if I had bleeding uncontrolled, like if the tissue are crying. But I don't use
standard drains,
not NG tubes, anything. Because patients now comes the same day to surgery, and they goes home the very next day. So we don't choose any drainage, only if it is mandatory. But we don't choose on a routine.
If you was unlucky and you didn't manage to stop the bleeding robotically, would you then convert to laparoscopic?
I think so. I think so. It's not unusual to move from robotic to laparoscopy, but usually with a robotic approach, we can manage almost all every difficult condition better than with laparoscopy, because we depend on laparoscopy. We depend of the camera holder. So if he is not skilled, we can be in trouble. In robotic surgery, we control everything. We control the camera. We control the exposition. We control all what you are doing. We don't rely on our aid, so we know what we are doing. Only to clean the camera. This is not.
Any questions? If not, there's only one. Is there any questions from anyone? Or
I think we have a panel discussion. There are a few questions for the whole panel, if that's okay.
Okay, then go ahead.
Yeah, okay. First question, is Duraid still with us?
He maybe went to bed. It's now 1 o'clock.
Okay.
No, I'm still here, guys.
Oh, excellent, Dr. Duraid. A couple of questions.
Sure.
The first one is about, you mentioned the enhanced recovery program in your patients.
Sure.
And you mentioned that's probably because I'm an anesthetist, you mentioned the erector spinal block in your patient.
Correct.
Is that the bilateral block you're using? And
I don't, yeah, I think so. The anesthetists do that. I don't interfere with their work, but we try to use very minimum opioid, maybe 50 mics of fentanyl on induction, but I use lots of local anesthetics. I use lots, so I use 1% Naropin, 20 mils plus 0.2 Naropin, 80 mils as a tab block with a vision. I use a 3D cameras, so I do 40 mils as a tab block between the external and internal oblique and abdominal muscles on the view. Yeah,
Right.
and that's why they do the RAS protocol.
Yeah.
Yeah.
The second question for you, Dr. Duraid, is that we are probably fortunate. We have an obese or probably morbidly obese prime minister who has changed his mind on obesity. And
Correct,
he
yeah.
promised to change to play his role in the political arena to change the view of the whole society in terms of managing weight better. How is things in Australia?
Australia is still, I think, with all of the world it's against obesity. I mean, Ali was right when he said there's a stigma. There is stigma, and everybody think that the problem is the patient, and it's not the obesogenic. It's not the environment. It's not the obesogenic environment we live in. It's not the genetics. It's not the brain set point. It's the patient. And I agree with Ali completely. Like, if you want to lose 10, 15, 20 kilograms, maybe it's not surgery. But more than 30, 35 kilograms, show me how you can do it and maintain it. And we force, I mean, we forced the diet industry to give us the raw data, because it's a big industry, it's a few $1 billion a year. And the results which we found, which is confounding, 1%, so 5% of the people who goes to the diet industry, you know, Weight Watchers and the others, they lose weight, but they don't reach the target after 12 months. But 5%, but only 1% of these 5% maintain it 12 months later. So it is a big thing, and it is a bigger problem. Unfortunately, even Boris Johnson, when he talks about obesity and he changed of mind, his BMI, it's a late 30s, early 40s.
Yeah.
But again, well, I mean, what are we talking about? We're talking about offering surgery for everyone. Well, we don't have the facilities. We don't have the surgeons. We don't have the bed. We don't have the anesthetists. We don't have the support. We cannot do that. I mean, in Australia, we're offering surgery for less than 1% of the eligible people. And if we're going to go to 1.1%, well, we're going to be struggling. I mean, we just increased 0.4. It is very struggle.
Yeah.
And we don't have the training program. I don't know. I mean, as I said, you cannot, bariatric surgery, you all need to be trained well. You cannot be gang-ho. It's not a cowboy. It's a training program. It's a mentoring. In your, I think I read somewhere when you guys say, هنا هو موفق لا يوجد الأعلم والأفضل والأحسن بالجراحة. هذا الكلام أصبح ماضي، أصبح يعني أنا دائما أقول عنه خريط. ما موجود الشخص اللي يقول هو أنا الأفضل في العالم أو أنا الأحسن أو أنا الأعلم بيناتكم. احنا نتبادل معلومات، بس لازم هاي المعلومات والخبرات اللي بيناتنا، بس لازم يكون هناك نظام. يعني احنا ما ممكن واحد يقول لي احنا بالعراق او بالعالم الاخر الثالث الناس كلها تستعمل السليف لانه هي ايزي، لانه ما يحتاج لها تريننج صعب جدا، بس زين المشاكل اللي بعدها وراها اللي تجي انت هنا تضرب من يعني when you are committed the patient to sleep, you need to commit with him or with her for the next 10 to 20 years. There is a risk of bariatric, risk of reflux, and a risk of revisions about 2 to 3% per year. So we're talking about 30% in 10 years revision rate. Who's going to do that? You need to be well trained. You need to be honest with your patients about the operation you offer and the support you give to them. So that's what I say. It's not for everyone. And one comment I just want to have and say, someone say that's a referral to see a surgeon 6 weeks. Well, I mean, look, well, the reason for that, we don't offer, this is not a cosmetic surgery. This is not someone who walking in the door, want the operations and leave. We send the questionnaires to the patient, then we contact them to have their, there's a coordinator, a nurse coordinator, to coordinate their visit to the dietitian, psychologist, exercise physiologist, about endocrinologist, to see the physician, to see the anesthetics. It takes time. If I have a failure in surgery, in a bariatric surgery, أنا في الفيلير مالتي ويا العراقيين اللي بأستراليا يعني يحاول ياخذ العملية يخابرك يقول لك أنا فلان فلاني ممكن تشوفني باكر أو بعد أسبوع وممكن يسوي العملية بعدها بيوم يعني ما ممكن يعني يتوقع انه هو عايش معه باي مكان اللي ممكن يدق الباب على الجراح يقول له ممكن يسوي له عمليه ثاني يوم وهاي ما موجوده يعني احنا اكو نظام هو اكو سيستم السيستم الهدف من عنده انه انت تنجح في العمليه وبعدين احنا عندنا كل شغله ثانيه ما اعرف اذا موجوده عندكم احنا عندنا موناش اوديت ونسوي الاوديت كل مريض يدخل عندنا يروح الى المستشفى تبلغ او والجراح يبلغ انه هو سوى هاي العمليه والمريض يكون فولو اب عنده. الحقيقه احنا الجاليه العراقيه والعربيه في استراليا الفولو اب مالته كلش ضعيف لانه يتوقعون هو العمليه يعني هو احنا ما عندنا سياحه علاجيه في استراليا يعني ما ممكن ان انت تجي من خارج استراليا وتقول اسوي لي عمليه معينه اولا غاليه جدا وهذا ما موجود احنا يعني on full capacity فما عندنا هاي الامكانيه فما عندنا هذا الحل انه انت تدق الباب علي تقول لي والله ممكن تسوي لي عمليه ثاني يوم لان انا محتاج اسسمنت وانا عندي تيم وياي حتى انجح حتى اوصل الى درجه النجاح اللي انا موجود الان بيها لازم انت تكون متعاون وياي ومتعاون ويا الفريق وهو مالتي ديسبلينري علي حكاها كلش صحيح it is a multidisciplinary team. It is a multidisciplinary approach. You cannot escape from that. A multidisciplinary approach.
Thank you.
Every patient.
Yes.
شكرا جزيلا.
Yeah, it's obviously the message is very clear. We have to have a system, and the approach is multidisciplinary approach. These are very clear messages to all our colleagues in Iraq as well. Now we have a question to Dr. Ali. If he's still there, not called for the on-call. Ali, are you still there?
Yeah, I'm there.
Okay, Ali. Ali, you mentioned in your presentation about genetics.
ايش خايف شو مستعجلين؟
Dr. Ali, yes, about genetics. And I would like to ask you, how far are we away from using the genetics and detecting children who are going to be obese in the future? Or is that something in the pipeline? Is that something coming in the future?
We're far away. We're far away, unfortunately. We're far away. We literally having very, very few knowledge about what the genetics will do. Even bile acids, even the microbacteria. We're not using all the potential of the medics yet. So far, the most successful part of treating obesity is bariatric surgery. But even that, as my other colleague says, the Dr. Abbas and Dr. Aqil, failure rate is between 10 to 30%. So the failure. So this is the best thing. We have 70% success in a sleeve, or maybe 80% or 85% success in a bypass. But that's not small. That's massive. So if we can imagine, each 100 sleeve we do, 30 going to be in the revision in about 5 years' time. So, I mean, the new thing in treatment of obesity, this is the newest. This has come literally a few weeks ago, 2 weeks ago, 3 weeks ago. Now, I mean, we know about the Saxenda, which is the liraglutide, which has been used as a medical treatment for patients who, for example, had grade 1 or 2 obesity, like BMI above 30 to 35. Now we have the semaglutide. The semaglutide just came literally a few weeks ago, and it's a 1-week injection. So I give the injections for once only for a week, and its effect, it's very promising. We're talking about 10 to 15% of total body weight loss, which is similar to the, let's say, a band.
Yeah.
So the advantage of this one is this is the most recent evidence. This was published literally a few weeks ago. Literally, it can be used in patients with BMI class 1 obesity, BMI of above 30 to 35. And second, it also can be used in failures and revision cases, or in patients who put weight after the bariatric surgery, which seems to be promising. Now, this is a very important point to say. The medication or the new treatment that's going to happen, or it's happening, is not going to compete with surgery. It's actually going to go in line. So we're going to work together again as a multidisciplinary team with the endocrinologist, obviously, and the physicians to be on one side, and they are going to be of a great help to us. So we're not competing. That's the whole point. It's a multidisciplinary approach.
I was very worried you will be made redundant because of...
Don't worry now.
Okay, there's a question, Ali, for you as well. Okay. It's about using semi-skim milk to reduce the liver size, I think, during surgery.
Yes,
surgery.
The liver shrinkage diet. Now, the reason we use liver shrinkage diet, so you can imagine the liver lies on the top of the stomach. So in order for us to do anything with the stomach, we have to lift the liver up, so we have access to stomach, so we can cut the stomach or whichever. So the bigger the liver, the unsafe the surgery. And the initial part of the weight loss for any bariatric patient is going to come from the liver. So we offer the patient to lose roughly about 5% to 10% of her excess weight. And this can be happened by any means. It doesn't have to be by semi-skimmed or low-calorie diet or whichever. I'm happy with the patients to lose this 5% of the extra weight before surgery, specifically with the high BMI patients. We expect to be a very large liver. And that's to make the operation safer for them, as simple as that. So it doesn't matter to be if it's semi-skimmed or full-fat milk or slim fast or soup with thin soup, not the heavy fatty soup. Anything will help.
Thank you, Ali. A question to Aqil, please. As I mentioned earlier about Boris Johnson and his attempts to reduce weight for himself and make the nation slimmer. Is there anything coming in the pipeline for bariatric surgery?
It is. I saw Boris Johnson many times on news, and there's already a fund release. I don't know how many millions to the primary care trust to help to fight obesity. I'm very pro for surgery. I don't think all these measurements for conservative approach to deal with obesity will be very helpful. The reason is there is a very good study already years and years called the Swedish study. Well, they recruit more than 4,000 patients in 2 arms, and they follow them up for 10 years. And we have enough evidence that conservative approach is not the excellent approach to deal with those patients. Second, the majority of those patients are diabetic, hypertensive, and long list of all comorbidities. If the patient, now we in the northeast of England, the percentage, it's about 40%. I had a patient with body mass index 101 who died at home actually. And the highest weight we done is 275 kilograms. So can you tell me if the patient with 275, how is he going to mobilize himself? I had a patient who did on him 5 surgery to get through 5, not because of complications, because of his comorbidities and his weight, so that we can move him from one stage to another stage. Yes, the government are more oriented now to deal with obesity, but I think, I'm hoping they will focus on the surgical bit rather than the conservative bit. Why West Europe, like Belgium, Netherlands, Germany? Belgium, for example, who is a very small country, they do more than 20,000, 30,000 cases a year. Would they waste their money for nothing? Because they knew obesity and medical consequences as a medical problem can be treated surgically. And because they looked at the topic from the financial point of view, so they think they save money and save patient life with doing surgery more than waste their time, waste their money. Each cardiac surgery, I don't know, it's very big topic. When they do intervention cardiology, for example, they do 3 stents or 4 stents, which cost at least £5,000. For a patient, he might die after 2-3 years. While when we reach for bariatric, which can save patient life and give excellent life quality, the money will be very difficult. So I'm hoping that with this topics, and Johnson will help to pump more money towards surgery rather than conservative option. I just want to comment for one thing for liver reduction diet. The idea of the liver reduction diet, it is mainly to reduce the glycogen storage in the liver. The reason is because each gram of glycogen holds 1 ml of water. So if the patient might lose some weight preoperatively with other type of diet, but the idea is to get the liver softer and smaller a little bit so that we can lift him, as Ali said. So that's the idea of the liver shrinkage diet.
Thank you, Aqid. A question to Dr. Adra Bhumrad and Adra Bhumrad. Dr. Adil, are you there?
Yes, I'm here.
Yeah, excellent. So when we go on holidays to Nice, we see the French people in very nice shape.
Yes.
Does that reflect the nationwide figures of obesity?
Well, it's different from if we take some region like the north, there's more prevalence of obesity there. In the central region where I am, we are above the average of the prevalence of obesity. It depends on the region, but what we must keep in mind is that obese person doesn't often go out, so we don't see him often in the streets doing jogging or something like that.
That's probably right. But compared to other European countries,
yes.
How France rate in that matter? I mean, is it like in the middle of the scale, or is it the highest of the European countries in terms of obesity?
No, we are not. We are under the average of. We are not. We don't have extreme obese. We don't have much obese. But the tendency is growing because we are eating junk foods. We are eating we left our French gastronomy, so we don't eat healthy food anymore.
Exactly. I think 20 years back when I went first time to Paris, I didn't see any McDonald's. Nowadays it's everywhere.
And you can see McDonald's with a green pancart saying it's healthy and everything like that.
Absolutely, yeah. Right. There's a comment from Dr. Anne Ziada. Empagliflozin or
Nadia Ziada.
Thank you. A comment from Nadia Ziada. Empagliflozin or other SGLT2 inhibitors are even better than semaglutide injection for weight loss, licensed for diabetes, cardiovascular disease. Dr. Ali, do you have any comment on that?
Yeah. I support the diabetologist's views. the thing is, you know, getting a drug approved to be used for treatment, it's really a long way. And so we just passed, you know, level 3 evidence for the semaglutide now, that is now ready to be used for obesity, and the patient does not have to be diabetic. So I totally agree that patient selection, there are drugs which are more effective than semaglutide. There are other ways than anti-diabetic medications, like again, bile acids, the combination of healthy bacteria that's given in your, there's plenty of combination of treatment that will show us that we are, you know, helping surgery, combining with surgery to do a better result for the patients. But we're not there yet. The whole point is we are not there yet. It's going to take another 10, 20 years until we reach this stage.
Thank you, Dr. Ali. Dr. Sabah Anai.
I would like to comment, please. My best regards to both Dr. Duraid in Australia and Dr. Aqil in the UK, as I'm proud of them. They were my student in Al Mustansiriya University Medical School. My regards to them and to all of you. Thank you.
استاذنا الغالي، لنا الشرف بحضورك استاذ صباح.
شكرا
جزيلا.
صباح استاذي، شكرا جزيلا وتحياتي لك. بس تعليق عندي على النيو دراجز اللي هو سيماغلوتايد، احنا بدنا نستعمله صار تقريبا حدود السنه باستراليا علي. النتائج ممتازه، بس المشكله وين؟ المشكله المريض، احنا عندنا واحد من المريض الاندوكرينولوجيست نزل 48 كيلو المريض. بس من اللحظه اللي المريض وقف الدراجز بيها الويت ريجين ستارتد. يعني هنا هي المشكله اللي احنا راح نعالج من عندها، انه الدراجز لازم يكون كومبينيشن، اتس مالتي ديسبلينري. انا دائما قمنا نصرخ بالبريه انه يوم عاودين اتس مالتي ديسبلينري، مو كل واحد بكيفه ومو كل لازم الكل يشتغلون سويه، هي دائما انه نتعامل سويه مع بعض. واستاذي دكتور صباح تحياتي لك، واني اتشرف اني تلميذك.
ثانك يو.
والعمر الطويل لك.
اشكرك. ثانك يو.
شكرا دكتور صباح.
دكتور صباح شكرا جزيلا على التحيه، واحنا يعني فرحانين نشوفك كل يوم. دراستنا في الصف الخامس كليه في الطب المستنصريه، وحقيقه يعني صدفه سعيده انه نلاقيك اليوم، فرحانين جدا بك.
شكرا جزيلا، الله يوفقكم.
دكتور صباح، انا سويت دبلوم تخدير بالمستنصريه واذكرك ايضا. شكرا جزيلا. وهذا طبعا هو الهدف من الجمعيه الطبيه العراقيه الموحده في المملكه المتحده ايرلندا، هي تجمع المجتمع الطبي العراقي والتواصل ما بينهم. عندنا الدكتوره خلود، اذا تتفضلي دكتوره.
مرحبا، أنا أتشرف بحضور هذا اللقاء المهم، وتحياتي لكم جميعاً. أنا تحياتي إلى أستاذي دكتور صباح عنائي اللي درسني في طب مستنصرية، وأنا جداً سعيدة اليوم أشوفه بخير وصحة وعافية. أنا عندي سؤال بسيط يتعلق بالconception of grapefruit and lemon drink after the food. Would that help conception of fat, or it's just mythology? Thank you.
Thank you. I don't know who's going to take this question.
خليل علي الحمداني دور هاي الشغلات.
يا علي باعتبار طب بغداد.
لا بالعكس استاذ صباح, it's really a pleasure having you. It's really a pleasure to having such a great قامة بالطب في يعني to present, to come and see us talking. We're all your students, even if I haven't worked in المستنصرية. So many thanks for coming really. Thanks دكتورة خلود.
شكرا.
Good question. بصراحة هو خلينا نرجع على الكونسبت. الفكرة انه مال the amount of energy that you have equal to the amount of energy that you produce. صحيح هي صحيحة, بس to put it in action is very difficult. هي the point at the end of the day انه to maintain the insulin hemostasis and the cortisone hemostasis. فما دام نحن we preventing this sudden surges in the insulin, then we achieve a significant difference. البيشنت ما راح يصير عنده هذا الsurge towards sweets or surge towards carbs that he will go after each meal. And then تعرفين ايش راح يصير طبعا، انت راح يصعد الانسولين يقضي على الجلوكوز، وراه يهبط الانسولين، بس يرجع كلش جوعان ياكل مرتلخ، وتستمر الحاله هاي السيركل. فبصراحه anything who can prevent this variation in the circadian normal circadian rhythm to preserve this normal circadian rhythm, that's the point. لذلك احنا نقول انه take 3 meals a day. It's absolutely fine. Have 3 meals. Have a proper English breakfast اللي هو كله sausages وهاي وعالقها. It's fine, absolutely fine. بس ما دام ما تاكلوا وياه carbs، ما دام ما تاكلوا وياه هذه، طبعا يعني هي شويه it's a difficult idea. But if you can imagine the stomach at the end of the day ما راح تفرغ شكو بيها. ما يفرغ شكو بيها اذا كانت سويت لو شوكلت لو كاربز لو لحم لو doesn't matter. من الستمك تملي حتى لو بس مي it will send impulses to the brain. I cannot eat anymore. That's it. فإذا نحن نملي الستمك ب something that can deceive the brain that we don't need the sweets. So if we نملي the stomach with fruits or vegetables, and when you eat let's say قونية برتقال بعد ما يقدر, it's fine, it's solved the problem. The brain بعد you cannot physically eat anymore, so the problem is solved. بس the question هنا انه راح يصير a gradual discharge of whatever you have in the stomach out. So if you discharge from the stomach carbs, it will disturb the insulin metabolism. But if you have a gradual discharge from the stomach into the small bowel of content, like for example, let's say fruits, vegetables, fat, then that's fine. Everything is controlled. Fine,
Okay.
have a job. I don't mind what you fill the stomach as long as it's healthy.
Thank you, Dr. Ali.
Thank you, Doctor.
A question to maybe Dr. Adra Bhumrad, if you can answer this. Is it advisable to have cholecystectomy with the SASI operation, or is it better to take urodeoxycholic acid to prevent biliary slugs and stones?
So what I do when we take in charge the patient for the first time, we ask him to do ultrasound. If he already got biliary lithiasis, so I do cholecystectomy before doing the bariatric surgery, and the bariatric surgery will come after 3 months or whatsoever. When I operate the patient, if he does not have a biliary problem, I give him ursolvent, and I don't do cholecystectomy. I do cholecystectomy only in case of duodenal switch, because we don't have any more access to the biliary tree, and this is the only time I do cholecystectomy, even though there is no problem with the gallbladder.
Thank you. Dr. Aqil, any comment on that?
Agree with Dr. Adil about not doing lab chole simultaneously with weight loss surgery. It is an old-fashioned idea. When they start bariatric surgery years and years, it was the trend to do simultaneously. And then again, a study came from, I think, Sweden, and they compare whether you do it pre or same simultaneous or do it after. And they find that you do it before the surgery is less complication and the outcome is much better. So I don't, and here again, in the UK now, we not do it at the same time. Simply is, if you have a post-op complication, you don't know whether this is from the gallbladder or from your operation. It's not recommended, and I agree with Dr. Adil.
Thank you, Dr. Aqil. And there's a comment, that question was from Dr. Sahar Hisham. There's a comment from Dr. Nadia Ziada. Lemon has anti-inflammatory properties. There's a question from Dr. Sahar Abdel Rasool. How do you prevent sudden surge of steroid if you are stressing all the time? Maybe Dr. Durait?
والله وهي جزء من عندها. شوف هي الستريس يعني حكاها علي، هي مشكله الشيفت وركرز والشغل والوضع بالعالم كله وكوفيد والعائله وعدم النوم لمده 8 ساعات كل يوم والحياه والماده والعلم والدين كلها متدخله كلها مسويه شوربه هي. فهاي طبعا يعني من الصعوبه واحد شلون يتعالج وياها، انه جزء من عندها انه تتعالج الستريس. لهذا هو السايكولوجي يدخل انه يحاول يساعدك على ايجاد طرق انه انت تقدر تتعامل مع الستريس اللي موجوده بحياتك، وهو يحاول انه وياك انه انت تفكفك الشوربه اللي صايره هي والسباجيتي اللي صايره بحياتك، حتى تشوف انه وين تقدر تسوي السيطره على الكورتيزون او السيطره على الستريس بحياتك. بس مشكله الليمون والجريب فروت انا بدي احب اعلق عليها ويا علي حكاها. هي صحيحه، علي قال انه الناس يعني شفتها هوايه من الناس يقول لك احنا شربنا جريب فروت والليمون. الليمون بفايبر وراح تاخذ جلاسين مي وياه انت، فراح تشعر بالشبع. يعني علي قال المعده راح تزج سيجنالز للبرين انه اني فول. فانت اذا عندك هاي القابليه انه انت تعلمت تسوي مايندفول ايتينج او انه تاكل من تكون جوعان، انت ما راح تزيد وزنك. يعني هي عمليه التريكينج للبرين. واحسن عندك سبيسنج ممكن يكون لانه الفايبر الموجود بالجريب فروت او بالليمون راح يطول لك السيرج بالهنجر سنسيشنز، يخلي لك اياها ممكن يكون ساعه اكثر، فانت ما تشعر بالجوع. لهذا الناس يقول لك والله انا قدرت اعبر عن منطقه الافترنون تي مثلا انا اخذت جلاس ليمون. هو هاي الفكره مالتها. واي شيء يعني انا I'm with everything to help. It's an add bonus whether it is anti-inflammatory او the reality انه والله هو بس دا يعبي معدته بجلاس مي وجلاسين مي وشويه فايبر وياها وليمون وطعمه طيب، يلا كلها تزيد.
بس يعني البوينت دكتور دويد اللي انا سامعها من جماعتنا والناس اللي نعرفهم انه يشوفون الجريب فروت وات ايفر ذيس افتر فود. That's a problem. I mean the food is already there. But in referring
هو يسوي سلو من الابزوربشن. هم احنا نعرف الفايبر راح يخلي لك سلو ابزوربشن، السنسيشن اوف فولنس راح يطول عندك. فهو هذا هو الفكره مالتها. بعدين هي تشمل الغرقان غطى.
الquestion referring to the
please, I must leave because I have another engagement. So thank you all.
Thank you very much.
Au revoir, comme on dit en France.
Yeah, au revoir. Yeah.
Au revoir.
Thank you, Dr. Adil.
Thank you. Yeah. I think by this as well, we come to finish all the questions. For you, Rafid, I would like to thank Aqil, Ali, and Duait, and Dr. Adra Bhumrad as well for their great presentations and participation. Rafid, all to you.
شكرا جزيلا مؤيد. Thank you very much indeed, مؤيد, and many thanks to the excellent speakers, عقيل, دريد, علي, أبو مراد, دكتور عادل. يعني فعلا كانت محاضرات رائعة جدا، مشكورين جدا. ونعرف يعني مشاكل السمنة اللي تأثر على كل مجالات الصحة والمجتمع ومجالات أخرى أيضا، ولمسناها طبعا من ناحية الكوفيد أيضا، ولمسناها أيضا من المريض يسوي العملية البارياتريك سيرجري وينزل وزنه كأطباء يعني فاميلي دكتورز، شلون قللنا علاجاتهم، قللنا علاجات السكري والضغط والأشياء الأخرى والمفاصل وأشياء أخرى طيب وحدها. يعني الأرثرايتس ما أتوقع إنه مريض كان بيه شلون راح، ما أعرف شلون، زين ما يحتاجون أي مضادات للألم. بصراحة يعني أحب أشكر الحضور أيضا. أريد أعلن عدة أشياء. أولا بالنسبة وعدت الأستاذ عبد الإله أنه يتكلم على شغلة الكوفيد في العراق وبصورة عامة، مو بس العراق. يعني الفاكسين الحمد لله في بريطانيا العمليات والحملات مستمرة يعني، وتشوفون يعني وصلنا حوالي 26 مليون أو أكثر. البارحة كان حوالي 660,000 جرعة فاكسين أعطيت البارحة، رقم قياسي. لكن أحب أن أنبه أنه لا زال الكمامة مطلوبة، غسل اليدين والتباعد الاجتماعي، رجاء التزموا بهذا الشيء. بالنسبة للعراق أريد أقول أيضا يعني رجاء للحكومة بالعراق، رجاء يعني كل الدول أخذوا الفاكسينز، كل الدول بدوا، حتى يعني ما أقول دول تعبانة، كل الدول بالعالم أخذوا الفاكسين، وحصة العراق موجودة منه. يعني ليش أنا ما أعرف شنو السبب بالتلكؤ في طلب حصة العراق من الفاكسين؟ يعني ماذا هذا التلكؤ وتعريض حياة الناس في العراق للخطر؟ رجاء من الجمعية الطبية العراقية الموحدة إلى كل المسؤولين في العراق العمل بجدية من أجل توفير اللقاحات للناس في العراق. يعني 50,000 جرعة جتي وهي هدية من الصين. يعني والله ما أعرف شو أقول. الشيء الآخر محاضرتنا قبل ما أروح المحاضرة، التيم وورك، يعني شيء حلو طرحتوه بالنسبة للتيم وورك، وهذا الكلتشر اللي تعلمناه في بريطانيا والدول الأوروبية. أتمنى هذا الكلتشر ننقله للعراق، وهذا هدف الجمعية الطبية العراقية الموحدة، كيف ننقل هذا المنتاليتي مال التيم وورك للعراق. بالعراق مع الأسف تربينا يعني من كنا بالعراق على أنه أنا الأفضل، أنا الأحسن، أنا العبقري. زين، حتى قامت تطلع كتب بهذا الشيء، هذا العبقري، هذا الأول، هذا الأفضل. زين، والناس يعني يلهون بعض المناصب. يعني مع الأسف إيران بتعلن عن هذا الشيء. إحنا تيم وورك، يعني كلكم شفتوا يعني في التيم أكو الممرض، وأكو البورتر، وأكو الفارماسيست، وأكو الفيزيوثيرابيست، وأكو الطبيب، كنا نفس المستوى بالعمل، لأن واحد يكمل الثاني. متى نوصل للعراق إلى هذا المستوى من عمل ماكو تعالي، وأنه العمل يتم بأسلوب العمل الجماعي؟ أحب أشارك وياكم محاضرتنا للأسبوع القادم، راح تكون محاضرة رائعة جدا. الحقائق حول الكوفيد يعني صارت بالحق الكبير، يعني الناس كونفيوزد، في تخبط كبير، ناخذ اللقاح ما ناخذ اللقاح، من اللقاح الزين، شنو اللقاح يسوي، شنو سايد افكت. أتذكر محاضرتنا السابقة اللي سويناها أخذنا أكثر من 40 سؤال من الناس إنه على اللقاحات وخوفهم من اللقاحات. راح يسوي محاضرة ثانية الأسبوع القادم اللي هي يوم الجمعة، الساعة 6 مساء بتوقيت لندن، 9 مساء بتوقيت بغداد. أساتذة راح يكون معنا أستاذنا الكبير الدكتور تحسين السليم، وأيضا أستاذ الدكتور شاكر جواد، وأستاذ دكتور علي إسماعيل، وأكون أنا تشير إن شاء الله أساعد بتقديم الحلقة. أرجوكم راح تكون الحلقة بلغة مبسطة للجميع، للأطباء، للتمريضيين، للصيادلة، أطباء الأسنان، ولعامة الناس. رجاء انشروا الإعلان، وحاولوا أكثر الناس أنه يحضروا المحاضرة لفائدتها لهم جميعا، ولفائدة العامة أيضا، وفائدة أهلنا في العراق والجاليات العراقية في بريطانيا وفي الدول الأوروبية أيضا. فرجاء شاركوا المنشور، وحاولوا تدعون أكبر عدد أنه يحضرون المحاضرة. كما قلت ستكون بلغة مبسطة جدا حتى نقدر نوصل المعلومة بسهولة، وراح نخلي تقريبا نص وقت المحاضرة هو للإجابة الأسئلة والاستفسارات ورد على الأكاذيب والشعوذة مع الأسف اللي الآن في العراق موجودة، والعالم أجمع، لكن بالعراق بصورة أكبر. أشكركم جميعا. وقبل ما أنهي كلامي، أحب أذكر أنه هناك لينك لتسجيل أسماءكم حتى تسلمون شهادة المشاركة، وأيضا حتى تعطونا الفيدباك. فرجاء إذا عندكم مجال تملون اللينك قبل ما ننهي اللقاء هذا. ومرة أخرى أشكر المتحدثين. دكتور دريد، أكيد صارتكم نص الليل، يمكن ما أعرف ساعتكم هسه
1:44 دقيقة.
الله يساعدك، أنا آسف جدا دكتور دريد، يعني ما توقعت هذا.
بعيوني يعني للشرف. شكرا جزيلا. شكرا عقيل على الدعوة،
علي دكتور عقيل على
عرفت عليكم.
درايد
شكراً
حبيبي،
دكتور
شكرا
عادل.
جزيلا، فرصه شفناك عيني.
بالخدمه، وانت وحسن واستاذنا صباح عنائي والزملاء اللي يعني دائما اشوفكم على الفيسبوك تحاولون، علي ورافد، بكل جهودكم انه تدعمون العراق اللي ما زال في بالنا وما زالت طعم التراب بعدنا، والزاد اللي اخذناه هناك نتمنى له انه يرجع مثل ما كان في يوم من الايام. وتحياتي لكم، ونتشرف وسعيد معرفتكم كلكم.
شكرا دكتور دريد، شكرا
شكرا
جزيلا.
جزيلا، شكرا.
ولا تنسون اهم شيء الحفاظ على صحتكم، صحه عوائلكم واهلكم، ولا ننسى الكمامه وغسل اليدين والتباعد الاجتماعي والفاكسين ايضا اذا تحصلوه رجاء. اي نوع من الفاكسين تاخذوه هو مفيد. كل الفاكسينات اللي منتجه لحد الان هي يعني معترف بها وتشتغل يعني. اما تقدم النسبه، حتى نسبه 10% انا اخذها اذا بها فائده. شكرا جزيلا لكم جميعا، شكرا للحضور الكرام، اسعدتونا بتواجدكم معنا، ولقائنا يوم الجمعه ان شاء الله في الساعه 6 بتوقيت لندن، 9 بتوقيت بغداد. شكرا جزيلا، ودامك الله بكل خير.
شكرا جزيلا،
شكرا جزيلا.
مع السلامه.
شكرا.
ألف شكر على المساهمات الحلوة منكم جميعا، وعلى
شكرا استاذ عبد الله، شرفتنا بوجودك، الله يبارك فيك.
روعة روعة.
شكرا لكل الاخوات والاخوه، يعني ما اذكر اسمائهم
جزيلا،
لكن انا جدا معتز بوجودكم معنا. شكرا جزيلا، بارك الله بكم وحفظكم.
شكرا دكتور رافد، اكسلنت.
شكرا دكتور صاحب، شكرا اخواننا الاعزاء.
شكرا عبد الله، عبد الله.
شكرا جزيلا، عيوني انا دكتور صاحب، الف شكر.
مع السلامه.
باي. Continue graduate.